for once, maybe just a few minutes, and then we'll...
Yes, I'll do that.
Once we start, yeah. Come if you can. Okay, can make me a host also, come co-host. Good evening, colleagues, and thank you. Welcome. We just submitting a few more people before we start the webinar, and it's always a pleasure to meet all of you every week as we engage in continued professional development with these webinars, and we bring you topics of interest to you. We've seen quite a number of you joining us in the last few weeks, actually from the beginning of the year. And it's been wonderful to see so many of you joining us every Thursday with these webinars. And it shows that, well, number one, you like getting CPD points, but two, we do have interesting topics, and we try to cover a wide spectrum of topics. And it's been a pleasure this year to have quite a number of our speakers coming from the Clinical Risk Committee, sharing their thoughts and their experiences, and also information on how to improve academic knowledge, medical knowledge, and also at the same time, because it's not only for head knowledge, but it's also to help us to be better clinicians, and also for the benefit of our patients that we see either in our rooms or in the hospitals or wherever we interact with patients. So I do trust that we are all better clinicians after engaging with these webinars. I know some of you would love to get ethics points, and we do our best to just not to cover clinical points, but also ethics points. Hence, next week we'll be having a presentation that will cover ethics points because that is where the demand is. And so this evening, we also continue with our webinars. And as usual, these webinars are streamed live on YouTube. So at any time when you wish to go back and watch the previous, almost at episodes, but previous presentations, you are at liberty to do so. Just make sure that when you click on the link, you just like us, so that at least you get reminders and always get these webinars, these presentations sent to you. And so this week, we're bringing back Professor Jeff Wing, who is a member of the Clinical Risk Committee at clinics, and also an endocrinologist, and also someone who's worked quite a lot within the public sector as the head of medicine at Charlotte Macleod Johannesburg Academic Hospital, and also head of Department Medicine at Wits University, and is quite involved with research work, working with the UJ, University of Johannesburg, and also supporting candidates to write their MD, and also working a lot in the research division, working with other entities. So we're quite happy to welcome him back this evening. And the topic that we'll be covering this evening is hyponatremia. It's something that is of interest to himself as the head of endocrinology in the past, and also working with quite a number of patients. Actually, this morning, Jeff, someone saw the poster and said, "Oh, quite an interesting person. I like him. I went to consult with him, and we had some engaging discussions on NHI, and we were just making some comments about that. And it's also one of the subjects that you want to deal with. And so I'm sure he'll be joining us this evening. And so it's a pleasure to welcome you once more to this webinars, and trust that many colleagues will quite enjoy listening to you and gaining a lot of insight on this topic on hyponatremia. Welcome.
Thank you, Ray, for that kind introduction, and happy to be part of the series of academic meetings as well. Can you all hear me?
Yeah, we can hear you. Maybe just a video for a minute, and then you can switch it off again, if possible.
You'll have to as the host, you must just allow me to switch that video on then.
Okay, can you please give Prof. Wing the right to be able to switch on this video?
There we go. Okay. So I'll switch the video off in a minute, so we don't upset the bandwidth too much. So I thought I'd start off with something a little perhaps more philosophical, is that the aspect of cellular biology, and therefore all life, is that cells want to be able to do all the following issues that is mentioned here: that express a gene, metabolize, transport, communicate with each other, and obviously divide. So that's a centrality of life and of each cell. And if we go back 40 billion years, which is seemingly the age of our universe, it all started with the formation of the early Earth, and that lowest slide at the bottom tries to depict that, where all the chemicals that make up cells and obviously all of life first arose from, and how they interacted to fulfill those cellular requirements that I just mentioned. And this obviously happened when an atmosphere developed on our primitive Earth and water was formed. So seemingly it rained. The seas were formed after continuous raining for about 10 million years. So this is where the milieu interior, the concept of this, was first postulated by the physiologists, where the salinity of the sea and of our intracellular and extracellular cellular environment occurred. And it's part of evolution that sodium homeostasis is apparent. Okay, let me advance. So the issue then, here's a saying about how life is. It's not what we know, but how much we do, and that brings us happiness. And if you interpose sodium into this, you can see when sodium is low, vitally, not only to get it normal, but the issue is how to get it normal to restore health. So this is the focus of tonight's talk, the low sodium. So I thought I'd start off with a few basic issues because it's a tricky subject and it's often confusing. So I thought I'd start off with the very basics. When we start measuring solutes and solutions, what are we measuring and what are we talking about? So physically, concentration of a solution is expressed as milliosmoles. So the mole is the unit of measurement. And we either express this in terms of milliosmoles per liter or milliosmoles per kilogram. So osmolality and osmolarity. So osmolarity is the former, where the there's a solution and something in it, and this is how we measure the concentration of that solution, expressed in liters. So obviously, when we do calculations in terms of sodium and osmolarity, we do it that way. However, when we do come to measuring, we tend to express it as an osmolality, and that's the lower one. This is the expression of that concentration per kilogram of the solution. And that, in terms of basic chemistry, is a better option because the latter is less dependent on water content, on pressure, on temperature. So it gives us a truer, more accurate reflection. But for all intents and purposes, clinicians, doctors, we tend to use the two interchangeably. If we then want to know within a solution what the actual concentration of a specific electrolyte is, i.e. the sodium, then we refer to the concentration as milliequivalents of sodium within a liter of the solution. Milliequivalents, as with all chemistry, is based on a standard where you compare, in this instance, sodium, its chemical effects in terms of how it can combine with other atoms relative to that of hydrogen. That's where the term milliequivalence comes from. So that's how we express a concentration of an electrolyte in a specific solution. When we refer to non-electrolytes, i.e. other molecules, peptides, etc., then the concentration is measured in millimoles per liter. Okay, so that just clarifies how we tend to talk when we talk about sodium in the context of hyponatremia. Okay, so this slide I'm going to spend some time on. I'm trying to merge some clinical aspects with pathophysiology. So I want you to spend some time on this slide. So when we talk about low sodium, what are we referring to? So obviously a sodium below the normal range being 135 to 145, anything below 135 milliequivalents per liter is regarded as low. So definition of hyponatremia, 135 and below. We then classify this low sodium as mild, moderate, and severe, obviously depending on how low the sodium is. So 130 to 134, 125 to 129, and below 125 milliequivalents per liter is regarded as severe hyponatremia. We classify this too in terms of the osmolality. And here we refer to hyponatremia and its effect on the osmolality of the solution, in this case, the serum. So we talk about hypotonia, hypotonic, isotonic, or hypotonicity in terms of the effect of sodium on osmolality. You see an asterisk next to hypotonia because that one is further divided based on the relative proportion of sodium to total body fluid. And I'll mention this a little later. We also classify hyponatremia in terms of how quick or how gradual it develops. So acute hyponatremia, 48 hours, chronic, more than 48 hours. And this you'll see is important in terms of its effect and its implication for management. Right, so management, as with all illnesses, we always try to find the cause, we treat the low sodium itself, and we look out for complications. Right, so going through this very briefly, isolated hyponatremia is very, very rare. It's normally secondary to another disease. So recognizing that is important. The actual low sodium, not unsurprisingly, affects the central nervous system first. The brain, as we all know, is very specific, very highly evolved, and the integrity of its milieu interior is vital for normal neurological functions. So we find that the impact of hyponatremia falls mainly on the CNS. And likewise, the complication. So if chronic hyponatremia is evident, osmotic demyelination occurs, and this often is severe, irreversible, and devastating. But at the same time, if sodium is low and we correct it too quickly, we seem to induce this demyelination syndrome as well. Okay, so let me move on just to elaborate on. Just want to click forward. Oh, sorry, I can't advance. Oh, sorry. Okay, so that advance. So remember I said when we assessing a patient with low sodium, we're going to define it as mild, moderate, or severe. We're going to measure the osmolality at the same time, and we're either going to see that the patient is hypertonic or isotonic in terms of osmolality, and lastly, hypotonic. When we find that the osmolality falls into the hypotonic range, we further classify, and this is the red upper panel. We further classify this into hyper, U, and hypovolemic, hypotonic hyponatremia. Right, so what does this mean? So the hyper, U, and hypo refers to total body sodium. So in this setting, total body sodium is either increased, normal, or low, hence hyper, U, and hypo. In relation to that, total body water can be increased significantly, increased to an extent, and even reduced. So it's the ratio of the change and the balance between sodium and water that allows us to subclassify the hypotonic hyponatremia into a hyper, U, and hypovolemic subtype. So this is important because if we understand this physiologic change and the pathophysiology that's related to it, we almost certainly are able to diagnose its etiology. At the bottom, it's often convenient to be able to calculate the serum osmolarity very quickly, and this is just one of the formula. 2 times the sodium plus the glucose in millimoles and the urea. So that gives you a rough indication of what the serum osmolality is. Okay, so as I said, clinically, the severity of hyponatremia is largely related to how it affects the central nervous system. So often where the abnormality is mild, there's very subtle symptoms, often asymptomatic, but sometimes just very mild durations in mental function. Where this hyponatremia is moderate, again, symptoms non-specific, lots of nausea, lots of malaise, lots of weakness. And where it's severe, we get significant neurological features. And I'm going to show you some of this now. Right. So severe on the left and more mild chronic on the right. So severe acute, nausea, vomiting, headache, lethargy, seizures, reactive pulmonary edema, coma. Milder, more chronic. So where it's chronic, obviously the neurons have time to accommodate the abnormality in low sodium, and the symptoms are more are much milder. fatigue, nausea, vomiting, dizziness, gait disturbance, forgetfulness, muscle cramps. So again, lots, as with many symptoms and presentation, not specific. So obviously, clinicians would have to look at these symptoms in the context of how they recur. In other words, is the patient at risk for hyponatremia or not? Right, so the physiology is easy and very basic. So from an evolutionary point of view, we have the kidney, the lung, the liver, and the posterior pituitary, all involved in this axis of homeostasis. So looking at the left, on the left, in the presence of hypotension, decreased blood volume, decreased sodium delivery to the distal tubules, reduced angiotensin II, atrial natriuretic peptide, sympathetic nerve activation. So the kidney senses too little intravascular volume. It secretes more renin. Renin converts angiotensin to angiotensin I, the former coming from the liver. As angiotensin I circulates through the lung, converting enzyme converts this to angiotensin II, and in turn, angiotensin II does the opposite of what sympathetic, it almost activates a sympathetic response, trying to increase perfusion to the kidney, vasoconstriction, increase resistance, increase blood pressure, increase cardiac output. So a neurovascular reflex. It signals to the adrenal gland to make more aldosterone, which in turn tells the kidney to preserve more sodium and water. And last but not least, posterior pituitary secretes more antidiuretic hormone, and more free water is reabsorbed, thereby increasing and restoring this homeostasis. So we all know this well. It's a very powerful mechanism. And as you would know from clinical practice, where this axis is over activated, it causes disease as well. All right, so the approach is here. So this I found the easiest way to try diagnose what is happening. So the approach, so the sodium is low. The next thing we do, we measure the osmolality. And here we define it as hypo or isotonic, a isotonic situation based on what serum osmolality is. 285, less than 280, and then normal, between 280 and 285. So if we look on, so that gives us an indication of low sodium and what the osmolality is. In terms of it's the effect of this low sodium on fluid status, as I mentioned, we subdivide this into 3 subcategories: hypovolemic, euvolemic, and hypervolemic hyponatremia. And here we look then at a third measurement, which is either the urine sodium or the urine osmolality. So let's look at this a little more closely. If you look on the left, urine sodium less than 20 milliequivalents. This is the typical surgical patient. The post-op patient, there's a fistula, there's an obstruction, etc., lots of vomiting, lots of diarrhea, lots of third space fluid collection. If there's hypovolemia and the urine sodium is high, then the causes here are either Addison's disease or diuretic use. If we look then to the right, where there's hypervolemia and the urine sodium is low, these are the overload states: heart failure, cirrhosis, nephrosis. And where in this setting of hypovolemia and volume overload, where the renal sodium is above 20, this indicates renal failure or renal dysfunction. If we then look at the middle column, euvolemia, in this setting, it's more appropriate to measure the urine osmolality rather than the urine sodium. And in this setting, what we're trying to do is exclude two big clusters of disease where the osmolality is high, inappropriate ADH, again, hypothyroidism, can't excrete free water in that setting, and where the osmolality is below 100, this is primary polydipsia, usually a psychogenic patient who drinks lots of water, or the odd individual who drinks too much beer. So if you look at this slide, knowing the low sodium, knowing the serum osmolality, and measuring what the urine does in terms of urine sodium concentration or urine concentrating ability, we can get a very good, clear idea of what the cause of the low sodium is. So I would say that in the surgical setting, it's more the hypovolemic option that we're going to be finding pattern. In medical patients, it's going to be more of the euvolemic and the hypovolemic type of hyponatremia. Okay, so inappropriate ADH is probably one of the most common medical causes of low sodium, and I just want to go through this a bit because it does allow us to revise the physiology that I've mentioned and reinforces the principles that we've mentioned. Right, so plasma osmolality is down, urine osmolality is up, euvolemia is evident, urine sodium is probably normal, and obviously look at other causes of hypoosmolality, euvolemia. Plasma osmols, those are the numbers that are typically evident. And in terms of other causes, the differential here would be diuretic use, hypothyroidism, and Addison's disease. So other tests that help is elevated AVP, uric acid. Urea is usually low. We very seldom do this water load test in the setting, so probably not needed. So this is how inappropriate ADH would be diagnosed. Causes are multiple, but these certainly are the most common. So malignancy, neurological diseases, drug induced is very, very common, primary pulmonary disease, and in the setting of South Africa, HIV disease. Right, so when it comes to deciding treatment, the big issue here is to realize what's happening with the neurone. So obviously, what we're trying to do is prevent and reverse intracellular edema, brain swelling. So whether hyponatremia is gradual, there's time for compensation, and the neurons can maintain normal size and not be subjected to overt cerebral edema. Where the hyponatremia is acute, obviously compensation is more difficult to achieve, and that's when we get overt cerebral edema. Right, so that's what it looks like, cerebral edema on the right. And this is obviously an emergency. All right, so what we're trying to do now in this slide is say, what are the fluids and what are, and can we quantitate in terms of sodium deficit what we need to do? So in terms of replacement, the most common options that are available is the use of hypertonic saline, 3% normal saline. At times, some clinicians would prefer to go a little slower and use normal saline. So in the top panel there, you can see that 3% hypertonic saline has 500 milliequivalents of sodium. And at the bottom, 1 ml per kilo of 3% will increase the sodium by 1.6 milliequivalent. Normal saline has 150 milliequivalents of sodium. Half normal and quarter normal saline obviously have those decreasing amounts. Okay, so if we're going to use saline, we know what our starting point is of how much saline we have therapeutically, and then in terms of maintenance, this is what we need to know, is that most of us would need 2 or 3 milliequivalents per 24 hours. We can work out sodium deficit. We can work out free water requirements. Particularly in the surgical cases, we can work out ongoing losses. So there's diarrhea, gastric, and where the patient is very febrile, what sort of losses we can expect. So knowing what strength of saline we have at hand, knowing what we need to maintain and what are excessive losses, we can pick what fluid and how quick to administer this. So let me go through then the treatment based on the severity of the hyponatremia. Right, so in the emergency, where this is severe, and particularly where it's acute, then the preparation of choice is going to be hypertonic saline. And two issues arise. Where there's impending herniation, then this hypertonic saline is given as a bolus. And I'll go through this I'll expand on this a little later. In the second situation, this is still an emergency, where the signs of severe hyponatremia are apparent. We still give hypertonic saline, but we give it as a graded infusion. So I would refer to this as a hypersevere emergency versus an emergency, where one is a bolus and the other one is an infusion. Where hyponatremia is mild, and particularly where it's asymptomatic, then supportive treatment is enough. And often we don't need to do anything except restrict fluid and perhaps augment salt intake in the diet. For the intermediate situation where hyponatremia is moderate and the patient is symptomatic, usually normal saline with or without medications will suffice. Furosemide, tetracycline, lithium, AVP receptor antagonists, and last but not least, urea. So I'll just expand on these a little bit. So this is the severe impending hyperacute emergency where herniation is being witnessed. So respiratory arrest, patients obtunded, starting to develop a decorticate posture and pupils dilating. So before saying that this patient is dead, if we know the cause to be acute severe hyponatremia, we will give 100 ml of hypertonic saline as a bolus over 10 minutes. Obviously, we're trying to reverse acute cerebral edema and then repeat if necessary. Okay, so this is for this very well documented, but not too common, as I would say, the hyper-emergency. Where the hyponatremia is severe and symptomatic, but there's no evidence of herniation or hyperacute cerebral edema, then hypertonic saline is given, either 3 or 1.8%. And here we want to give it as a slower infusion. So remember what I said, chronic hyponatremia and rapid correction or overcorrection of hyponatremia causes osmotic demyelination, and that's what we're trying to prevent. So it's almost working between a rock and a hard place. If you don't do anything, demyelination occurs. If you go too quickly, demyelination also recurs. So here, the plan is only to raise the sodium by 0.5 milliequivalents per hour and not to go above 130, not to achieve a plasma sodium of greater than 130 within the first 2 days. So aggressive in terms of getting the sodium to 130, but then slowing down much quicker. Right, so going through what we've just discussed again, 3% hypertonic saline. Ironically, and this happens in many of these acute emergencies, there's never been level 1 evidence accumulated in this regard, but it's just what our predecessors did, and no one obviously from an ethical point of view is going to design a study to say whether 3% or 1.8% is better than the other. Okay, so obviously its indication is those severe instances of hyponatremia where there's significant neurological fallout, and where this happens, especially where this happens acutely within the 24, 48 hour space. And hypertonic is also useful when we started off initially with normal saline and it's not working, or the therapeutic outcome is not obtained. Right, so continuous effusion is useful, as I mentioned, in most instances. Where there's overt volume overload, we combine this with furosemide. So there's many recipes to say how we infuse this in the setting of severe hyponatremia. And basically, as we said, is to get to a level of 130 milliequivalents after 48 hours. And a useful algorithm is to say, if we think the patient's 80 kilograms, we're using a 3% hypertonic infusion, and we infuse this at 80 mils an hour. So 80 mils per hour of a hypertonic saline in an 80 kilogram patient will increase the sodium by 1 milliequivalent per hour. So that gives you a nice rough algorithm. Obviously, if the patient is 60 kilograms, you would convert the 3% infusion to 60 mils per hour and get the same result. And obviously, in terms of monitoring, measure the sodium every 4 to 6 hours. So remember, the rate of sodium correction in terms of preventing demyelinization is much more important than the infusion rate. So the idea is to infuse at a rate that achieves this slowly. Okay, so again, this is a summary of mild. All right, and the pros and cons and limitations. So fluid restriction works in the mild case. Problem here is obviously you have to police the patient in terms of fluid restriction. Increased salt is easy. Dietitian can help all of us with that. Tetracycline, it reduces the ADH response. The dose is a standard antimicrobial dose. It works very well, but in the setting of chronic kidney disease, polyuria, or skin disease, it has those limitations. The ADH receptor antagonists, the one that I think is available is an intravenous preparation, effective and very little side effects. Other medications, as we mentioned, and side effects and precautions, diuretics. So this is often useful in the setting of dilutional hyponatremia in those cardiac cirrhotic nephrotic patients, particularly useful in that setting. Tetracycline, I mentioned, useful more in the chronic stage, chronic cases where we know the cause is inappropriate ADH. Lithium also inhibits the effect of antidiuretic hormone, and we see this more as a complication of lithium treatment in patients with bipolar disease. But with the inverse, it's also effective in chronic inappropriate ADH secretion. Limitations of lithium shown on the right, CNS, cardiotoxicity, and important here is other side effects such as thyrotoxicosis or even hypothyroidism. So it's interference with thyroid hormone production. Urea is also used as an osmotic agent, and however, this may aggravate renal dysfunction. So I would say in terms of medication, the only ones that we really use more often and more safely is either the use of furosemide in those specific patients and tetracycline in the setting of chronic inappropriate ADH. The last three slides I thought is useful because in the setting of hyponatremia or potential hyponatremia, we often have to allocate and prescribe fluid treatment. And I thought I'd just give you what hypertonic, hypotonic, and normal saline do. Right, so this is half normal saline, 0.45, useful for that DKA patient where you need lots of free water. Obviously, avoid where cerebral edema may occur, such as head trauma, burns, and liver failure, because here implication is you're giving too little sodium and too much free water. 5% dextrose is even more hypotonic because obviously it's the dextrose in the dextrose water is utilized very quickly, and basically this is giving free water. So very useful for mixed, it's useful where medication has to be given in the setting of hyponatremia. So it's basically tap water given intravenously. And obviously we must avoid it with where hyponatremia and diabetes is evident, and also hypokalemia. Hypertonic saline, okay, useful only for severe hyponatremia and where there's raised intracranial pressure and all those cerebral stigma that I mentioned. Right, so as we mentioned, very select indication for 3% normal saline and only really one indication, severe hyponatremia. Normal saline versus ringers, useful for most of our patients, particularly if we're trying to avoid hyponatremia. So this one I won't go into because it's very familiar to all of us. Okay, so the last slide is a summary, and I've expanded on that second slide. So the take-home message is when you see someone with hyponatremia, classified into mild, moderate, and severe, measure the sodium osmolality, decide whether this patient is hyponatremic in the presence of increased normal or low osmolality. And in regard to the latter, decide whether there's hyper, or euvolemia. And then the algorithm will help you decide on the etiology if we then revert to measuring urine sodium and urine osmolality. Importantly, in terms of how we treat the patient, if this happens acutely, less than 48 hours, we expect more cerebral fallout, and we're more aggressive with treatment, particularly in the use of hypertonic saline. And where it's chronic, we can probably be less aggressive and use less aggressive options. Again, just remember, if we neglect chronic hyponatremia, or if we treat it too aggressively, we induce that demyelination complication. Again, isolated hyponatremia is rare, always associated with a secondary, as part of a secondary issue in some other systemic disease. And we went through the issue of non-drug treatment for the mild patients, the use of various concentrations of saline, and perhaps 2 or 3 useful medications for more chronic cases, particularly if the cause is inappropriate ADH. And then last but not least, beware of that demyelination syndrome with chronic hyponatremia, or iatrogenically if we correct this too quickly. Yeah, so thank you, and happy to try and answer questions.
Thank you very much, for this insightful presentation and of sodium, and basically we talk about salt. There's been a question about salt intake, and there's also another question about how much water should one take, because someone has said that we normally advise patients to limit their salt intake. And how would you advise? What should we advise them to do? We know that we also like spicy food, and I've listened to some colleagues sometimes giving lectures about how much we affect our bodies by taking with so much of the spice that we put in our food. So, generally, how much salt intake should we have, or not? What do we give to patients, and how much water should one take? You go to boardrooms, or you walk in the malls, you find people walking with bottles of water, and this Dr. Bugait says that there's a patient who takes about 10 liters per day. What's your advice?
Okay, so again, I would suggest that I think you're right, is that modern humans are addicted to salt and addicted to sugar, to refined glucose containing foods. So we would all know that healthy eating is cutting calories, cutting salt, and cutting refined sugars. So the question is always how much. I don't like to give a quantity to say you must only eat or only have so many teaspoons of sugar or not. I think rather than quantify it I think what I do with my patients, and this is obviously not in the setting of acute hyponatremia that I mentioned, but this is in outpatients, is to say, try lose weight, try cut down on refined sugars, don't add too much salt to your food. And when it comes to water or fluids, obviously in winter, summer is a little bit different. Whether you're a manual worker and you tend to sweat a lot, or whether you're an office worker and you sweat less, is to say the minimum that you need in terms of free water clearance and renal perfusion, you need a minimum of 3 liters of water a day. And that would suffice healthy living for most instances. Obviously, if you're a manual worker and you're working in the sun, it's going to, or you're working on a farm, it's very different. but in general, 3 liters of fluid, particularly water, suffices. The patient that drinks 10 all the time may be at risk for that polydipsia syndrome that we mentioned in terms of hyponatremia as well. So we're talking about healthy patients, obviously, in regard to fluids. We're not talking about patients in renal failure or cardiac failure, where their fluid must be restricted.
Okay. And in the compliant patients who don't take too much salt, are they not in danger of being hyponatremic? That's a question that actually the Boyados was asking.
So I think unless you're sweating excessively, the answer would be no. Those homeostatic mechanisms, the renin-angiotensin ADH axis is very, very powerful. So unless your sodium intake is absolutely zero, those homeostatic mechanism will allow the kidney to retain sodium.
Okay. In DKA, which is better, Ringer's lactate compared to normal saline? I think
normal saline. If you ask the endocrinologist, they would tell you normal saline. If you ask the intensivist, who tend to treat many of these DKAs, they will tell you Ringer's lactate. The answers probably makes no difference. There is a small difference in terms of potential more acidity, lactate, with Ringer's lactate rather than normal saline. So some of the endocrinologists would ascertain that you want to stay away from Ringer's lactate if the patient is overtly acidotic. But it probably makes little or no difference whether you use normal saline or Ringer's lactate in that setting.
Okay. So why is that the physician, the endocrinologist and intensivist differ?
I think some of it is academic fashion. Some of it is who's more traditional, the endocrinologist, because that's how it's always been done. And therefore, there's no indication to really change it. The intensivist would look at the patient from a more technical point of view, I think, in terms of how they measure acidosis. So I think it's more personal preference and more academic grandstanding.
Now, because you spoke about
evidence that one's better than the other.
You spoke about the rate of infusion and also whether you do regular sodium checks to check if you're correcting. And the nurses, how should one be able to talk to them? Because one is entirely dependent on nurses to be able to give solution to the patients.
So Dr. Bieler, you're obviously referring to the patient with severe hyponatremia, with neurological fallout. We're giving the hypertonic saline, or we're giving the normal saline. For the former, remember, we want to increase the sodium by 1 milliequivalent every hour and not exceeding 130. So we're going for the lower limit of normal. So I would think for the nurses is they would have to order a UNE every 4 hours in that patient and make sure that the sodium is increasing, but at the proper rate. So not too quick. So here the problem is very difficult, as I said. If the sodium stays low all the time, we get that demyelination problem. If we recognize severe hyponatremia and we correct too quick, we also cause the problem. So the idea is to be aggressive in giving saline and to be very careful and safe in measuring how fast we're increasing it. So we have to give sodium, but we can't give it too quickly. So remember, get the sodium to 130 over 2 days and measure every 4 hours to make sure you're attaining that. But don't normalize acutely.
Okay. So there has to be a constant communication between the nurse and the doctor. I mean, I'm looking at maybe in
Yes, and the
the public
lab.
settings, you're dependent on the intent to be able to go there, and every now and then for hour you check that. But
Yes.
say in a setting where the doctor is not there, operating from home, or in the district hospitals, you've got fewer doctors being able to do so. So the nurse is quite important, but they also have to understand the readings.
Yeah. Yeah.
Okay, colleagues, anyone else who's got a question? I don't see. Okay, there's this one also, Dr. Tutet. How does ecstasy cause hyponatremia?
Look, I'm not too sure, but because it's centrally acting, I presume it's going to be inappropriate ADH. Is going to be the likely mechanism. So it's inappropriate ADH.
Yeah. Okay. Colleagues, anyone else who still has a question to? I've seen some nephrologists who've joined us. Any roles for them? Because I think hyponatremia today, some of these patients end up with a renal. I mean, we spoke about hyponatremia. I know that it's not but they do end up with renal dysfunction at some stage if untreated.
Not unless the cause is renal itself.
Yeah.
Yeah.
Okay. Questions, colleagues? Anyone? It's a very difficult subject. As I see, with a fewer questions, it's other colleagues quite have to internalize this presentation. Or
yeah, it's one of those finicky topics with lots of physiology and overlap.
Yeah. But I think you went through it very slowly and I think methodological. So that one, we have to be able to go back and watch and look at the slides to understand exactly what you are discussing. Yeah, there's another question. What is the effect of alcohol as a diuretic on the sodium balance?
Okay, so alcohol initially would inhibit ADH, right? And then during the post-binge stage, you get a rebound in ADH. So you dehydrate in terms of free fluid, and then during the recuperation phase, when stop drinking, there's a rebound in ADH. So the patient is prone to water intoxication. So that's the issue of hyponatremia. So it's in the post-binge phase. So some people even think it contributes to the hangover, a little bit of cerebral edema.
Taking too much, yeah. And is the recommended amount of water per day the same for males and females, Dr. Leandro
Sure. Probably, yes. Yes. I mean, at the onset, I would just say yes.
There's no difference in terms of intake.
There's no gender. There's no major gender difference.
Yeah. No. Sure. We've just covered this within an hour with a good presentation and also good discussions here. Okay, I will answer this first. Can I ask Professor Judith Booth, who's our member of the risk committee, also to do the closing remarks and a vote of things? Of course.
Oh. Oh, there you go. I had to wait for the host to unmute.
Okay, thank you.
Thank you.
Sure.
And also, I can't show my video, but I'm sure that is okay. Thank you, everyone. I see there was a very, very high attendance, over 400 participants. Ray, can I just check if you can hear me?
Yeah, I can hear you. We're loud and clear.
Cool, thank you. So, Professor Wing, Jeff, as I know you, thank you very, very much for an insightful and interesting presentation. You really took us back for over 40 billion years and reminded us about the salinity of the sea and that of the human body, in particular the serum. And that began the discourse around sodium homeostasis. That was a very interesting fact. But what it also does for me, having worked in the teaching and learning space among university students in health sciences, it reminds us of the importance of understanding the molecular basis of disease and aberrations in the body. So it's very important that students in health sciences, whether they're doctors, nurses, physiotherapists, begin to understand the molecular basis of disease in their undergrad curriculums. Thank you also for reminding us about the etiological factors. And very often living in South Africa, we forget the importance of HIV disease and how that can affect patients in all aspects of how they present to us in hospitals. And you just emphasized how important that is as an etiological factor in hyponatremia. Yeah, there were a whole lot of things you told us about. Thank you for the classifications. Very important that we understand sodium, the osmolality, and the time in which we treat. And the 48-hour rule is very important in acute cases. You mentioned to us the various fluid replacement options, pharmacotherapy, and I found your algorithm particularly useful in calculating the infusion rate. And I think that is also important for nurses and other health professionals to appreciate. I would like to just thank you in closing to also just to remind participants from what we understand, hyponatremia is quite common amongst people. And in fact, 15 to 30% of in-hospital patients can present with hyponatremia, regardless of the diagnosis that they've been admitted with. In just a recent study in a trauma ICU in Durban, they found that 68% of patients in that ICU actually suffers from or experience hyponatremia. And amazingly, fluid overload is the most common cause of hyponatremia in that cohort of patients. So that was a very interesting fact. And I think you really drove home tonight the importance of monitoring and that this is not just in the domain of the doctor, but the multidisciplinary team, and that we always have to have that approach in being vigilant over monitoring patients' blood electrolytes. So thank you very much for that, Jeff. And I think, Ray, that is all for this evening, unless you want to take any further questions. Thank you.
Thanks for that, Julie. I think we've come to the end. I'll do that question for that person who wanted to ask a question. Or maybe let me just take it, Jeff. I know that people have just they want to leave, but it's the last question before we log off. Oh, there are quite a number that are coming after we've done some vote of thanks. It's about hypertensives. Do we encourage hypertensives not to take salt and they get hyponatremic? Does that affect them negatively? And the last one is about the late question, SGLT-LI and no hemostasis.
Sorry, what was that second one, Ray?
I'm not sure. SGLT-I.
Oh, SGL2 inhibitors. Okay.
Oh, okay.
Okay, so the former one, hypertension and salt intake, it's still advisable to reduce sodium intake because of the blood pressure, because it aggravates hypertension. And in that setting, patients are not subject to hyponatremia. So if you restrict dietary sodium, it would be very, very and most unusual for that patient to develop hyponatremia. It may happen, though, in the setting is if they're taking diuretics. So the only time I would say hypertensives are prone to a hyponatremia, these would be usually elderly patients on a diuretic. The second question on SGL2 inhibitors, remember by their mechanism of action, they do have a diuretic effect because they induce an osmotic diuresis. And obviously there would be some sodium potassium loss with that. But if hyponatremia is a complication of that, it's probably very, very mild.
Thank you very much. Yeah, I think, colleagues, we've run out of time, and thanks for the late questions, and also Jeff, Profin, for going to respond to those questions. This brings us to the end of the webinar. We just want to thank everyone, as Professor Bruce has just said, and we hope to see you again next week. We want to thank Kamo and Anza from marketing for helping us to put together these webinars every week, and also for Clinics Health Group for allowing us to host these webinars on a weekly basis. So, colleagues, have a good evening. Meet you again next week. Bye.
Thank you. Good night.
Night.
Good night.
Good night from Zambia. Musiki.
Yes, yes. Good night.
Good night.
Thank you. Good night.
Thank you, Dr. Soma. Night.